Welcome back to This Explainer. Today, we're putting on our clinical educator hats and looking at something, well, truly mind-blowing. I mean, we live in an era of million-dollar medical scanners, right? But today, we're going to see how some of the most low-tech tools in optometry, literally pieces of paper and little plastic wands, can completely save a patient's vision, and sometimes, honestly, even their life. Let's get right into it. You might be wondering, can a simple piece of paper actually save a patient's vision? I know, it sounds almost absurd when we have advanced lasers and optical coherence tomography just down the hall. But here's the reality. If you're in a primary care setting or doing a domiciliary home visit where you obviously can't just drag a massive machine through the front door, these so-called crude paper tools are absolutely essential. They are literally your very first line of defense. Okay, let's dive into this. Here's our quick syllabus for today's masterclass. First, the macula with an Amsler Grid deep dive. Second, the optic nerve and the power of the red dot. Third, we'll hit the periphery for a confrontation masterclass. And finally, we'll wrap up with the conclusion, covering limitations and referrals. Starting off with Section 1, the macula, our Amsler Grid deep dive. All right, so this is where we look at the absolute center of our visual world using the Amsler Grid manual. It is incredibly simple to perform, and best of all, it's totally portable. You get 7 grid options in this little booklet. So if you have a patient whose ability to cope with complex or automated tests is maybe a bit reduced, or you're visiting them in their own residence, this booklet right here is your best friend for assessing that macular function. Now, the absolute crucial point here is the number 30. If you're a student heading into your clinical exams, I'm telling you, write this on the back of your hand. The Amsler Grid must be held at exactly 30 centimeters from the patient's eye. Not 25, not 40, exactly 30 centimeters. Let's walk through that non-negotiable clinical setup. First up, the patient has to wear their full correction and near addition, basically their reading glasses if they need them. Second, as we just aggressively established, hold it at exactly 30 centimeters. Third, this is a monocular test, meaning we're testing one eye at a time. And step 4, which is honestly the most critical instruction you will give your patient. They have to keep their gaze totally fixed on that central dot at all times. No wandering eyes. So why 30 centimeters? Well, because of the number 10. When you hold that grid at exactly 30 centimeters, the outer borders project perfectly onto the central 10 degrees of the retina. It gives you a highly specific 10 by 10 degree map of the macula. It's just simple geometry doing all the heavy diagnostic lifting for you. And when you actually map out these results, it brilliantly illustrates what happens when things go wrong. While the patient stares at that center dot, you're asking them, are any lines wavy? Are there any holes or missing spots? Those dark blobs they might describe? That's a scotoma, which is basically a giant pothole in your vision where the image just completely drops out. And those wavy, distorted lines, we call that metamorphopsia. It's exactly like looking through wavy glass. If your patient is describing this to you, their macula is waving a massive red flag. Moving right along to Section 2, the optic nerve, red dot power. Next up, we have the red dot perimetry chart. It's such a brilliant, quick way to screen for subtle optic neuropathy or macular disease. It's really just a central black dot surrounded by red dots. But this actually begs a super fascinating clinical question. Out of all the colors in the rainbow, why do we specifically use red? Here's the trick, and honestly, most people miss this detail. A massive 70% of the normal optic nerve is actually composed of macular fibers, which represent your cone function. And physiologically speaking, these cones have a peak response to broadband wavelengths greater than 600 nanometers. In plain English, that is the color red. By preferentially stimulating these specific cones with the color red under high room illumination, we can actually uncover hidden optic nerve lesions. It's amazing. So, how do we interrogate the patient's vision with this setup? You ask them to look directly at the center, and then you ask, are all the red dots present? Are any bits of the dots missing? And crucially, you ask, do all the surrounding dots look equally red, or do some look brighter, and maybe others look kind of washed out? A washed-out red dot is a massive diagnostic clue for an optic nerve issue. You're literally mapping their nerve health just by asking them about color saturation. All right, Section 3, the periphery, our confrontation masterclass. Let's move out to the edges and see how this builds our visual map. We've checked the center, we've checked the nerve, now we need to look at the wide outer limits of the visual field. There are 2 main variations of peripheral testing you absolutely need to know. Gross perimetry involves moving a target in a flat plane between the patient and the clinician. But confrontation perimetry? That requires moving the target in an arc centered right on the patient's eye, at a distance of about 33 centimeters. You bring the target slowly around from a position where they can't see it to one where they finally can, stopping right at the center. To pull this off, you typically use a 5mm white target on a wand, and you test across multiple meridians. You are quite literally comparing your own normal monocular visual field with the patient's field. Now, in normal field for a white target stretches out pretty far. You're looking at about 100 degrees temporally, 75 degrees inferiorly, 60 degrees nasally, and 65 degrees superiorly. It gives you a really great rapid assessment of their overall peripheral vision. Now, what's really interesting about this technique is the other end of that wand, the 15mm red target. Why use red way out in the periphery? Well, because checking for color desaturation across the vertical midline can actually enable a significantly earlier diagnosis of a neurological lesion. For example, a chiasmal lesion caused by a pituitary tumor in the brain. You compare the color of that red target across the 4 quadrants, and if the red suddenly looks dull or gray the second it crosses the midline, you might just be the very first person to detect a brain tumor, all with a little plastic wand. No way, right? And that brings us to Section 4, Conclusion, Limitations and Referrals. Now, as incredible as these tools are, we do need to put our academic educator hats back on for just a second. We have to acknowledge the limitations here. These techniques are purely qualitative. Yes, they're fast, they're simple, and they're essential when high-tech gear just isn't around. But they are also crude. The background lighting can vary wildly depending on what room you happen to be in. They are fantastic for identifying gross defects in the visual field, but let's be clear, they are absolutely not a replacement for full diagnostics. There's a great quote from the source material that sums this up perfectly. If a defect is suspected using gross perimetry, further investigation using more sophisticated instrumentation is indicated. That right there is the golden rule. Finding a wavy line on an Amsler grid or a washed-out red dot isn't the end of your exam. It's the exact trigger moment where you sit down and write the referral. You're using the low-tech tool to justify bringing in the high-tech cavalry. Which leaves us with this final thought. If a simple piece of paper or a little plastic wand can reveal a hidden brain tumor or a degenerating macula, what else might we be missing by rushing past the simple steps? These manual clinical skills aren't just ancient history. They are the absolute bedrock of patient care. Thank you so much for joining me on this explainer. Keep practicing those fundamentals, and I'll catch you in the next one.